So my task today is to take you through the wonderful world of interstitial lung disease. So I'll go over the different types of interstitial lung disease that you may see. We're going to review some board review cases, go over the diagnosis of these interstitial lung disease, and then also how we manage them. So the definition of an interstitial lung disease, it's basically diffuse parenchymal lung diseases. It's a very heterogeneous group of lung diseases, but they all have some similarities between them. The main challenge is really to figure out what exactly you're dealing with, because that is going to influence how you manage these people, but also what their prognosis is going to be. This is the most recent classification of interstitial lung disease. It has gone through a couple of revisions along the years, but this is the one that we use nowadays. The main ones I'm going to address are the ones that you're probably already are familiar with, or at least have heard of. So that being IPF, NSIP, or non-specific interstitial pneumonia, respiratory bronchiolitis, ILD, desquamative interstitial pneumonia, or DIP, cryptogenic organizing pneumonia, which we actually see a fair amount of time in the ICU, and then acute interstitial pneumonia. I'm not really going to touch on the ones down here. They're very rare. Maybe the one thing you need to know is, for example, lymphoid interstitial pneumonia. If they ask you something about it on the boards, in children, it's associated with AIDS. In adults, it's usually associated with Sjogren's disease. And this last one is a newer interstitial lung disease that has been described maybe over the past 10 years. Very rare, but presents with sort of upper lobe fibrosis along with some pleural disease. But again, that we rarely see that one. So let's start with a case. So this is someone that I saw in clinic a couple years back. So he's a 64-year-old white male with a history of obesity, hypertension, diabetes, and also has a prior history of pulmonary embolism. He presents with sort of non-specific symptoms. He's just getting progressively short of breath with exertion. He's a non-smoker. He used to be in the military, but is currently retired. He does have a pet pig at home. His review of systems is otherwise non-remarkable, and we'll talk a little bit later about what exactly we as pulmonologists look for in the review of systems when we're seeing these patients with ILD. And then you always want to ask a good medication history. So you can see his medications here, but nothing that sort of stands out. On exam, he's an obese male. He's satting 95% on room air. He has inspiratory crackles at his basis bilaterally, but he does not have clubbing. So again, these are some of the things we focus on as pulmonologists. And these are his PFTs. So I know you all love seeing PFTs, but the first thing we do when we review PFTs is we look at the loop. And what you can tell by this loop here, it's a very narrow loop. So this would be a classic example of a restrictive loop. And then we confirm that by looking at the numbers. So we look at his FEV1 to FVC ratio, which in this case is 80% of predicted, which is normal. But we're already on the spirometry, we're getting a hint that there's something wrong with his lung volumes, because his FVC is 50% and FEV1 is 51%. Then we look at the lung volumes, and you can see here that his TLC, or total lung capacity, is at 43% of predicted. Anything above 80 is considered normal. And then the other thing, we look at his gas exchange, or DLCO, which is also moderately reduced at 62% of predicted. He then goes on to get a CAT scan. Now, this is not his CAT scan, but this is a good representation of his CAT scan. So the first thing you want to do is you want to look and see, are you dealing with the upper lung zones or the lower? And in this case, you're in the lower lung zones. And you can see that there's too much white stuff in the periphery, or what we call reticulation, so small extra lines. There's some traction of bronchiectasis, right? So you can see these bronchi that are dilated almost all the way out to the periphery. And we call it traction is because these airways are getting pulled apart by the surrounding fibrosis. And then also what you see here at the very periphery is these cysts. And you can see that there's more than one layer of cysts. There are about 2 or 3 layers of cysts. And so this is what we call honeycombing. So what would your next step be? And we'll just sort of think about it as I read out the options. So you can refer him to pulmonary for a bronchoscopy with transbronchial biopsies. You can refer him to thoracic surgery to get a VATS lung biopsy because you want a bigger piece of tissue. You can start prednisone and azathioprine thinking that this is some inflammatory disease. Or you can refer him for a multidisciplinary discussion, a panel of pulmonologists, radiologists, pathologists, as well as rheumatologists. So I will go back to this question as we go through. So he basically has what we call IPF, or idiopathic pulmonary fibrosis. It's a chronic progressive disease. We really don't know what causes it. There's a thought that maybe gastroesophageal reflux is involved, but that the data there is really not that clear. It affects older adults, males more than females, and it's really a disease that's limited to the lungs. They present fairly nonspecifically, right? It's sort of progressive dyspnea on exertion. They can have a dry cough. Sometimes when they go to their internist or any other provider, they'll sort of hear some crackles at the basis bilaterally. They may or may not have clubbing. And again, it usually presents in older men, so 6th to 7th decade, and more common in men. And when you do Pfts, just like our patient had, they will have a restrictive ventilatory defect, and then their gas exchange will also be low. Before you come to the diagnosis of IPF, it's very important to exclude anything else, right? IPF is really a diagnosis of exclusion. So one of the most important things to exclude is autoimmune causes. If you look at the recommendations from the American College of Chest Physicians, it sort of gets a weak recommendation, but really when we see these patients in clinic, we will do a little bit of a rheumatologic workup, unless, for example, it's the typical 75-year-old male, in which case the odds of them having rheumatological disease is unlikely. But this is from an article in Chest, and there are a couple things we look at. So when I mentioned the review of systems before, it's really to ask about sort of these rheumatologic associated symptoms. So for example, do they have any rashes? Do they have rhinos? That's really one of the most important ones we ask about. Do they have sicca symptoms, right? Dry eyes, dry mouth. Could you be thinking about Sjogren's? Do they have dysphagia, acid reflux, which again you might see with patients with scleroderma? And do they have proximal muscle weakness, thinking about polymyositis or dermatomyositis? And in some of these diseases, the lung process can actually start before the rheumatologic process. On exam, again, you're going to pay close attention to the following, looking at the hands, looking for ulcers, mechanics hands, looking for ulcers, proximal muscle weakness. And then on laboratory, this is usually the basic panel that we will send in most patients. Again, if it's a 75 or older male, we may not, but otherwise these are what we look for. So ANA, double-stranded DNA, scleroderma antibody, anti-Ro, anti-La, rheumatoid factor, CCPs, anti-Jo1, looking for more myositis, CK, aldolase, and cedrate and C-reactive protein. There is a way to sort of help you with these patients when you do a history. There are questionnaires that are available. So for example, from UCSF or National Jewish, that really go through the whole exposure history, right? Exposure is going to be very important for these patients. So for example, have they been exposed to asbestos, or do they have birds at home? That makes you think more of chronic hypersensitivity pneumonitis. Do they have a hot tub, which again can cause some mycobacterial disease? So these are all things you want to find out for them, and sometimes it's easier to hand them a questionnaire and have them fill it out. The other main thing we do with these patients is we really look at the high resolution CT scans that we get on them. And I can't emphasize enough, if you do see these patients, it's very valuable to discuss these CT scans in person with our thoracic radiologists here, who are Pranay Krishna and PJ Berquist. And recently, this classification was revised, and this comes out of a paper from Lancet Respiratory Medicine. It's basically the Fleischner guidelines on how to interpret these high-resolution CT scans. And this is a group of radiologists who basically came up with these 4 categories. And so, depending on these 4 categories, there's a likelihood that the patient truly has IPF. So for example, if you take a typical UIP CT pattern, and it's basically what I showed you before, they will have basal predominant and subpleural reticulation. They will have honeycombing, and they may also have traction bronchiectasis. If you see all those in a CT scan, the likelihood of it being a typical UIP pattern is very high. And if you've excluded everything else, this patient most likely has IPF. In probable UIP pattern, they have all those features, but they don't have the honeycombing. Honeycombing, if you remember, are those cysts that you see in the periphery that usually form 2 to 3 rows. It's actually quite difficult to make a diagnosis of honeycombing. Even if you ask multiple radiologists, they won't all tell you that it's honeycombing. So there's not a great degree of sort of concordance even amongst radiologists. CT pattern indeterminate, so there you have some features, but you really don't have the honeycombing, and again, it just doesn't look quite right. These are the patients that most likely will end up getting lung biopsies because you just are not sure what it is. But despite that, about 80% of them will still end up having the UIP pattern, even if it doesn't look classic on CT. And then these are things that are just not consistent with IPF. So for example, upper lobe predominant. Again, before I told you this is really a lower lobe predominant disease. If it's peribronchovascular predominance, so again, for that, we think of things like sarcoidosis. If they have a lot of cysts, if they have nodules, air trapping, and all those features, this is really not consistent with a UIP pattern. So just to show you some examples, this is from that article. So again, you always want to find out which part of the lung you're looking at. Always look at the coronal CTs because this will give you a nice way to look at distribution, right? So for example, if you look at these, you'll see that there's more disease in the lower lungs and none in the upper lobes. And again, here we're looking sort of for that honeycombing, so the rows of cysts that are layered on top of each other. So if you see honeycombing, that makes it a definite UIP pattern. As opposed to this, where there's no honeycombing, but you still see this sort of peripheral basilar predominant reticulations, and this is someone that would fit in the probable UIP category. So in the past, open lung biopsies, so VATS lung biopsies, usually really were the gold standard to diagnosis. But now we've gotten better with CT scans. We also use this multidisciplinary approach, again with different people, and discuss the cases, and most of the times the patients will not need a VATS lung biopsy. Going back to the question I asked you before, transbronchial biopsies are really not sufficient to make the diagnosis because the pieces of lung are just too small. There's a new technique called cryobiopsy, which uses a sort of a freezing technique via bronchoscopies. It has not been widely accepted yet because there's a fairly high risk of hemorrhage. And so VATS is really the gold standard. It's the next best thing where a thoracic surgeon will take a couple pieces of different lobes. If you're doing a VATS as an elective procedure, the morbidity mortality is about 1%. If you're doing it as sort of an emergent procedure and someone who came in with progressive dyspnea has a terrible looking CT scan in the ICU, then the mortality goes up to 16%. And that was actually shown by a couple different papers, and most recently by a study from Nathan's group out at Fairfax. So again, depending on if you suspect IPF, if you can think of any other disease that it might be, then obviously it's not IPF. If not, then you're going to base your diagnosis on high resolution CT scan. If it's a definite UIP pattern, it's most likely IPF. And if not, then you may have to consider a surgical lung biopsy. So this is on pathology what it looks like. So it's a very heterogeneous disease, meaning that you will have normal lung tissue and then areas of fibrosis. And if you look closely, you can see that these alveolar interstitium is very thickened, and then you have these fibroblastic foci, and that is helpful in the diagnosis of IPF. So until a couple years ago, we really had no treatment, right? And one of the questions I'd asked you is, could you use prednisone and azathioprine? And that has actually shown to worsen mortality in patients in IPF, and that was the Panther trial that was published quite some time ago. But in the last, I would say, almost 10 years now, we've had two drugs, two antifibrotics that we use for these patients. The first one I'll mention is nintedanib, so it's a tyrosine kinase inhibitor, and that has been shown to slow the progression of disease in patients with IPF. And this was based on two trials, the Impulsus 1 and 2, which were randomized controlled trials, which showed that basically the rate of FVC decline was lower in the patients on nintedanib than the ones on placebo. One of the main problems with these drugs is there are a fair amount of side effects. So really GI side effects. In the case of nintedanib, diarrhea and nausea. The diarrhea, you can use Imodium, and sometimes it does get better over time. But one thing to remember with these drugs, and the second one being Prophedone, is It slows the progression of disease, but it does not make patients feel better. So their quality of life does not necessarily improve, and sometimes the side effects are just too much for these patients. But this is the second antifibrotic trial, Prophedone, again, randomized controlled trial, which shows that it decreases the rate of decline in FVC. And you can see that here again. So it was statistically significant. So both of those have been approved for the treatment of IPF. Again, the main problems with these drugs are GI side effects of nausea, dyspepsia, but then Prophedone can also be associated with a photosensitivity rash. So you have to tell your patients when they go out in the sun to really cover themselves up from head to toe, use SPF 50 and hats and long sleeves, etc. So if you have patients, for example, who are avid gardeners, this may not be the drug to use. As far as which one to use, there's really been no head-to-head trials. So it's more patient preference as far as side effects, to be honest with you. Both of these can have some liver enzyme abnormalities, so it's something you have to monitor monthly for the first 3 months and then every 3 months. And again, this is an example of the photosensitivity rash that I was describing with Prophedone. If the patients are warned about it and if they know that it can occur and if they cover themselves up, then you don't have to worry about this. Lung transplant is obviously the ultimate treatment for patients with IPF. So these are some of the indications. One of the main ones is if their FVC decreases by over 10% in 6 months. This has been shown to be associated with a higher mortality. They do have to participate in pulmonary rehab before, right, which is sort of an exercise program, usually 36 sessions, where patients with any lung disease, to be honest, do the treadmill, the stationary bike, they do some, some weights, and also it's associated with classes. So it's very helpful in general for patients with lung disease. It improves quality of life, but it has not shown to improve mortality. But it is a prerequisite for patients who are going to get transplanted. So this is some older data, but if you look at sort of why patients get lung transplant in the US, so COPD is actually the #1 cause in green, and then IPF is a close second. As far as mortality, I would say about 5-year mortality is about 50% following lung transplant. Patients with cystic fibrosis tend to do better. They do get double lungs, right, because of the high risk of infection if you leave one infected lung in, and also most of the time they're younger patients. There's an entity called combined pulmonary fibrosis and emphysema that I'll just mention. So it is what it is. So upper lobe emphysema and then lower lobe pulmonary fibrosis. They tend to have a worse prognosis, mostly because they have more pulmonary hypertension. And these can be tricky because on Pfts, if you think about it, their lung volumes are going to be preserved because they tend to air trap because of the emphysema. So whatever the pulmonary fibrosis is reducing your lung volumes, the emphysema is going to increase. So again, as I mentioned before, if you have this UIP pattern, for example, in pathology or even in high-risk CT, you need to make sure it's not something else. So for example, asbestosis can give you a UIP pattern. Sometimes you'll have the history that they've been exposed to asbestosis, and also you can look for pleural plaques, right, calcified plaques, mostly on the diaphragm. Connective tissue diseases, so for example, the one that's most commonly associated with UIP would be rheumatoid arthritis, but you can see it in scleroderma, you can see it in some of the myositis. Drugs and medications, so nitrofurantoin is one of the ones we think about, and then chronic hypersensitivity pneumonitis. So this is basically sort of an allergic reaction to some allergen, usually an inhaled allergen. And there was a study done back in 2013 in Barcelona where they really took these patients and looked to the extreme for any allergens. And they were able to prove that in almost 50% of patients, you could maybe find an allergen that explained their underlying lung disease. They present just like IPF patients, right? They have progressive dyspneic exertion, fatigue, cough. You can have some crackles on exam. The one that's most commonly associated with this, for example, is birds, right? Birds fancy your lungs. So that's why as pulmonologists, we always ask about birds at home. But the other thing is down comforters, down jackets, and things like that have also been associated with hypersensitivity pneumonitis. One of the differences between the sort of IPF and hypersensitivity pneumonitis is hypersensitivity hypersensitivity pneumonitis tends to be more upper lobe predominant because that's where you inhale more things. And if you do biopsies, you may see sort of some loosely formed granulomas, which are pictured here. So again, it's sometimes hard to distinguish between the two. Some IPF is usually, as I mentioned, it's sort of a progressive disease and patients slowly get worse over time. There's some patients who tend to do fairly well or stay stable, but then all of a sudden something will happen. And this is what we term sort of acute exacerbations of IPF. We're not really sure what causes them. These are the ones that you may see in the ICU. So they have underlying fibrotic disease. And then if you do a CAT scan, you may see this diffuse ground glass. And you don't know, is it volume, is it infection, or is it just some sort of inflammation? Really no good data on treatment. I mean, we will give them high dose steroids. And then the problem is after one of these exacerbations, they never get back to where they were before. So it is associated with higher mortality. There is some thought that maybe nintedanib might prevent this, but again, the data is not completely out there yet. All right, so I'm going to move on to smoking-related ILDs, and I'll sort of I'll go through these maybe a little bit quicker because I think the most important ones for you to know is really IPF and then NSIP and organizing pneumonia, which I'm going to talk about a little bit later. So smoking-related ILDs come in three sort of flavors: respiratory bronchiolitis, ILD, and DIP, or desquamative interstitial pneumonia. And basically what they are made of is these pigmented macrophages which will accumulate along the bronchi. So usually in RB-ILD, it's males who've had a fair amount of smoking, 4th to 5th decade. They again present with progressively shorter breath and cough. You can hear some crackles. Rarely do they have clubbing, and then they tend to have a mixed pattern on Pfts, meaning they have obstruction but also restriction. And they're obstructed because they're smokers and restricted because they have this lung disease. If you look at the CAT scans, what you're going to see, and you have to probably trust me on this because I'm not sure how well it projects, but they have central lobular nodules, which are mostly upper lobe predominant. And then if you do biopsies on these patients, again, this is all nice normal lungs, and then you get to areas around the bronchi where you see this interstitial inflammation. And if you look closely, and again, you're going to have to trust me on here, but you see these brown cells, and these are the pigmented macrophages. This is a close-up of these. Again, so this is probably a normal alveolar here. You can see it's nice and thin. And here you can see that it's thickened, so there's some interstitial disease, and then these pigmented macrophages. It's really a clinical diagnosis. A biopsy is not necessary. You can do a BAL on which you may see some pigmented macrophages, and the main treatment is smoking cessation. Sometimes you can use steroids, but these patients, if they stop smoking, have an excellent prognosis. So DIP is another one of these smoking-related interstitial lung disease, and this one will present with sort of diffuse ground glass, and most of the time this does require a biopsy to make the diagnosis. So this is an example. Again, these are the lower lungs, and you can just see this diffuse ground glass, so this haziness in both lungs. And if you did a biopsy, you again can see that the alveoli are very thickened. There are a lot of cells, right? Blue cells a lot of times are lymphocytes. And then in some areas you will see some pigmented macrophages. The treatment for DIP is smoking cessation, but these patients don't do as well as the RB-ILD because it's sort of more advanced disease. So you will probably have to use steroids. Not all of them respond, and some of them actually go on to needing lung transplant. All right, so let's talk about case 2. This is another patient I remember seeing in the ER. So this is a 45-year-old Mexican female who had no past medical history, but she presented with progressive onset of shortness of breath over a 9-week period. She was a non-smoker. She worked as a cashier at 7-Eleven. She reported no exposures. She wasn't taking any medications, but on a review of systems, she reported changes in her nail beds and her fingertips. She looked well. She was sitting 94% on room air, but when we ambulated her in the emergency room, she dropped to 88%, and she had some inspiratory crackles at the basis bilaterally. So again, might be hard to see, but you can see that she sort of has some changes around her nail beds, and this has been going on for the last couple of months. We did PFTs on her. So again, you can see the loop is narrow, so restrictive pattern. Her FEV1 to FVC ratio was normal, so no obstruction. But her TLC was reduced at 58% of predicted. And she was actually so short of breath that she could not do the DLCO, which requires a breath hold technique. This is her CAT scan. So this is very different from what I showed you before. So again, it's the lower lobes, but here you see sort of this haziness, this ground glass as we call it, and there's also some areas of traction bronchiectasis in here. There's no honeycombing, and again, it's not necessarily all peripheral, and there's a lot of ground glass. So again, sort of just to think about it, what would you do next? So you can do transbronchial biopsies. You can do a lung biopsy and referring them to a thoracic surgeon. You can refer to rheumatology to have them do more of a connective tissue workup, or you can just start prednisone. So again, in this case, biopsies are probably not going to help you either way because of her finger findings and her nail bed findings. She probably has an underlying rheumatologic condition, and also her age and being female. Those are all give you a higher chance of having an underlying connective tissue disease. And then we probably wouldn't start prednisone because we just don't know what she has yet. So if you look at the pattern on CT scan, she has what we call NSIP, or non-specific interstitial pneumonia. It really can present at any age, any sex, any sort of males, females. They usually present non-specifically with dyspnea and cough. Sometimes they can have fever. You can hear crackles on exam. And same thing as with IPF, they're going to have a restricted ventilatory defect with a reduced DLCO. It can be idiopathic, but most of the time it's associated with an underlying connective tissue disease. And it really can be any of them. Here I listed the most common ones, and sometimes it can precede the connective tissue disease even by years. So these are some of the symptoms or some of the physical findings you may have when you're looking for connective tissue disease. I'm not a rheumatologist, but these are some of the things to sort of think of when you're seeing these patients, and I'd already mentioned some of these before. And again, this is the workup that you can do looking mostly at the antibodies. And as pulmonologists, we will start a workup, but we will also refer to rheumatology to sort of help us out with these. There are two different societies that sort of give you guidelines. The one I just showed you was from American College of Chest Physicians. This is from the European Society. They pretty much recommend sending the same antibodies. The main difference is they also recommend sending an anti-MDA5 looking for myositis, and also the PL7, PL12, which again, we usually don't necessarily do as a pulmonologist. We will refer to rheumatology to help us with that. If you look at the high resolution CT scan for NSIP, just like our patient had, it's more ground glass. There can be some traction bronchiectasis. It's usually lower lobe predominant, sort of as here, so you can see the ground glass, but then you can also see the traction bronchiectasis. And if you do a biopsy, it's going to be a more uniform distribution. IPF has areas of normal lung and abnormal lung. In this case, most of the lung will be abnormal. And when you look closely at higher magnification, you see that the interstitium is thickened. There's also something mentioned in the literature. Sometimes NSIP can sort of present with subpleural sparing. So again, you can see sort of this darker line at the periphery. It's not pathognomonic for NSIP, but it can help you. And here also what you see, you do see some sort of scattered ground glass and also some evidence of bronchiectasis. There are two types of NSIP. There's a cellular type and then a fibrotic type, which is basically as it sounds. So if you look at this biopsy, again, the alveolar septa are thickened and it's very blue. And I always tell my fellows if it's blue, that means there are a lot of cells, usually lymphocytes, versus on this side, you have more pink. So that represents more fibrosis. So again, if you want to look at the difference between UIP and NSIP, UIP, it's a subpleural disease with honeycombing, versus NSIP, it's really this ground glass opacities, and sometimes you can see this subpleural sparing. How do you treat NSIP? It really depends on what disease is associated with it. And again, I'm not a rheumatologist, but these are some of the medications we use. So they're all immunosuppressants. And depending on what disease state, we might choose one versus the other. So for example, tacrolimus or Prograf is really chosen more for the myositis. But again, it varies from case to case. I think the one that we feel most comfortable with is the mycophenolate, and I'll tell you a little bit why that is. So this is a scleroderma lung disease study that Dr. Steen and Dr. Reed were part of, and this is looking at cyclophosphamide versus placebo, which did show a positive effect. And then scleroderma ILD2, the subsequent part of this trial, was looking at mycophenolate versus cyclophosphamide, and both were found to be about equal. And so mycophenolate is much easier to tolerate for patients, so most of the times we really have been using that. And this is also some retrospective data from National Jewish looking at mycophenolate in a wide variety of connective tissue disease associated lung diseases, and also showed some benefit. So usually these patients will start with a steroid, so prednisone, but we'd like to give them a steroid sparing agent to sort of decrease the side effects from prednisone, and that's where we may choose mycophenolate or any of the others that I sort of pointed out. Now, in the last couple of years, as you can imagine, these antifibrotic drugs, which were approved for IPF, have been looking sort of for other diseases that they might help. So this is the Census Trial that, again, Georgetown, Dr. Steen was part of, looking at nintedanib in the use for systemic sclerosis associated interstitial lung disease. So it was a double-blinded placebo-controlled trial, and you can see that the patients with nintedanib had a less decline in the FVC. So we do use that now for patients with scleroderma-associated ILD. And then recently there was also another trial looking at nintedanib in patients who had progressive ILD. This progressive ILD could be from rheumatoid arthritis, from chronic hypersensitivity pneumonitis, from sarcoidosis, from a lot of different diseases. And that was also a positive trial for patients because it decreases the rate of decline of the FVC. All right, so that was at SIP. Now let's talk a little bit about this next one. So this is a 55-year-old African-American female who had no past medical history, but recently had recurrent episodes of fever, shortness of breath, and productive cough. She had been seen by urgent care, her PCP, and had gotten multiple courses of antibiotics, really without getting much better. And then finally, she was admitted with respiratory failure, required intubation, and underwent bronchoscopy with just a lavage that was negative. And these are, this is a representative cut of her CT scan. So what you see here, again, it's the lower lobe. There's a little bit of motion artifact because she's intubated, so it's more difficult to do CT scans. But you can see here, there's sort of some consolidation down here, almost like plate-like. It's almost like a linear density. And then there's also some ground glass in this lung. So again, what would you do with this patient? Would you continue broad spectrum antibiotics? Although I can tell you by now she's been on them for a couple days. Would you start empiric steroids? Would you do bronchoscopy, but this time do some transbronchial biopsies? Or would you refer her for VATS lung biopsy? So she's been on antibiotics before and really hasn't improved. So A is probably not the answer. B, we sometimes do, I'll be honest with you, but we always hesitate a little bit when we don't know exactly what they have. You could do bronchoscopy. You may or may not get the answer, but if you really want to know for sure, then you would send her for a VATS lung biopsy. So, and she had what we call cryptogenic organizing pneumonia, or COP, or organizing pneumonia. A lot of times when we do biopsies on pathology, they'll sort of mention this organizing pneumonia. It really mimics community-acquired pneumonia. So that's why these patients tend to have a history exactly like the one I just gave you, with sort of these recurrent episodes of infection that don't get better with antibiotics. It's a subacute illness, and again, they present with cough, shortness of breath, and they can have fever. The main findings on high-resolution CT scans is the teaching is sort of the cryptogenic organizing pneumonia can almost look like anything. It can have sort of this consolidation, look like a pneumonia. It can be bilateral and have some consolidation and maybe some more areas of ground glass. Here you can see it's sort of like almost like a mass in the left lower lobe, or it can have sort of these linear consolidation. So it really can look like anything. If you biopsy these patients, what you'll see is these polypoid tissues that are sort of in the airways. The main treatment is corticosteroids. Most patients have a good response. but they tend to relapse. So you sometimes have to use a longer course of duration. And some of them will be left with a little bit of progressive interstitial fibrosis. It's interesting because if you look at, for example, COVID patients, some of them will have some residual changes on CT scan. And the thought is that this probably does represent a form of organizing pneumonia. And sometimes you can also have a combination of organizing pneumonia and NSIP. And a lot of times that's associated with polymyositis or the antisynthetase syndrome. You can have what's called secondary organizing pneumonia, which we probably see more often than cryptogenic organizing pneumonia, but it's usually associated with something else. So for example, rheumatologic diseases, again, rheumatoid arthritis, polymyositis, it can be drug-induced. Some of the hematologic malignancies can be associated with it, and also some of the immunodeficiency states. And these actually tend to have somewhat of a worse prognosis. So, and the last one I wanted to mention is acute interstitial pneumonia. This used to be called Hammond-Rich. It's an idiopathic, rapidly progressive pneumonia with carries a very high mortality, usually more than 50%, and there's really no proven treatment. So, and for the world, it looks like ARDS, right? So it's bilateral dense consolidations with some ground glass. In these patients, the most important thing to do is to rule out something called acute eosinophilic pneumonia, which also can present with rapidly progressive respiratory failure. When you do a BAL in eosinophilic pneumonia, you'll get a lot of eosinophils back. And in those patients, if you treat them with prednisone, they have a very rapid response to the point that they could be on very high vent settings and extubated within a day or two. So it's really quite dramatic. And that's why we sometimes do BALs in patients like this, especially if we don't know what's going on. And again, this is just more pictures, but you can see the dense consolidation mostly in the bases. And if you biopsy these patients, you'll see what's called diffuse alveolar damage, which is really non-specific, which also is seen in ARDS, but it's basically sort of these pink lines here, and it makes the lungs very stiff.